Okay, sure. I think we are a quorum. I think we can start. So once again, ladies and gentlemen, welcome to today's session. This is a continuation of last week's session where we discussed a history case presentation on childhood pneumonia. Today we are going to discuss the second part of the session, which is the topic presentation, which is going to be presented by our colleague Nabeela Sharif, a level 5 medical student. We are also again honored to have with us Dr. Adil Waris. Dr. Adil Waris is a consultant pediatric pulmonologist and a lecturer at University of Nairobi and Aga Khan University for 17 years. Mashallah, we have with us someone who has a lot of experience and wealth of knowledge to share with us. Please, let's engage and we benefit, inshallah, maximum from it. Nabeela, are you ready to share the screen?
Yes.
Kindly go ahead.
Please disable me.
I think you can now share. Sorry about that.
Can you see my screen?
Yes, you can. Doc, welcome. I hand over the session to you, inshallah.
Assalamu alaikum. My name is Nabeela Sharif, and today I'll be taking you through pneumonia in children. So these are my objectives. By the end of this presentation, we should be able to define pneumonia, be able to classify, understand its pathogenesis, the signs and symptoms of pneumonia, how to investigate, management of pneumonia, and most importantly, prevention of pneumonia. To begin with, pneumonia is the single largest infectious cause of death in children worldwide. Deaths are highest in South Asia and Sub-Saharan Africa. So in Kenya, it's the second leading cause of mortality in children under 5 years old, accounting for 14 to 15% of deaths. This is similar to the worldwide statistics as by the WHO guidelines. 13% of cases of severe pneumonia require hospitalization. So this is a graph showing the burden of illness caused by pneumonia. So we can see that this purple line indicates pneumonia mortality. The blue line indicates diarrhea mortality.
Nabeela, you're breaking up. Nabeela? Nabeela? Nabeela, you're breaking up. We cannot hear you clearly. Can you hear me, Nabeela?
Can you hear me now? Yeah, can you hear me now?
If you have two electronic devices that are close to each other, it might be. Are you just using one device today? Nabeela, can you hear me?
Hello.
Mohammed, has she logged off by any chance?
No, she's on.
She's still there?
Mm-hmm. Nabeela, can you hear me? Maybe we give her a second to correct that. Yes,
Hello?
yes. Yes, I can.
Okay, so let me start it again.
No, just start this second slide. Nabeela, are you using two devices or one device?
One device.
Okay, fine. We heard epidemiology well. Move to the next slide, please.
Okay.
And if you can just restart this
So,
slide, this is where we got lost.
Okay. So this is a graph showing the burden of illness caused by pneumonia. From the slide, we can see that the purple line, let me just use a pointer. The purple line is indicates mortality, pneumonia mortality. The blue line is mortality due to diarrhea. The green line is the incidence. So from this graph, we can clearly see that mortality due to pneumonia peaks below the age of 1 year, then decreases as the age increases. Also, in addition to that, the pneumonia also accounts to a higher percentage of mortality as compared to diarrhea. So the factors contributing to high pneumonia morbidity and mortality includes malnutrition. So malnutrition makes a person more susceptible to infections such as pneumonia. Poor hand hygiene, lack of safe drinking water and sanitation, indoor and outdoor air pollution. Approximately half of child pneumonia deaths are associated with air pollution, indoor air pollution being more than outdoor. So the indoor sources include like cigarette smoking, combustion of fuels like charcoal, wood, and for the outdoor sources can be due to industrial processes like mining, combustion of fuel like charcoal, like coal, and poor access to healthcare also is a factor that contributes to high morbidity and mortality due to pneumonia. So what is pneumonia? Pneumonia is the infection of the lung parenchyma.
Nabeela, go back one slide, please. So, dear colleagues, also remember that when we're talking about indoor air pollution, that we are also talking about scented candles and the mosquito coils that burn round and round, and the oud that I talked about the last time when we were having a conversation on pneumonia. So please remember that there's a lot more to indoor air pollution than just a parent who is smoking. Okay, the kerosene, the firewoods, all those paralyze the mucociliary escalator, making children more susceptible to infections. Carry on, Nabeela. Next slide.
Okay, so pneumonia is the infection of lung parenchyma, and that includes the alveoli and respiratory bronchioles. And the causative organisms include viruses and bacteria. So pneumonia can be classified according to the causative organism based on the severity or anatomically. So on the anatomical classification, pneumonia can either be lobar, bronchopneumonia, or interstitial pneumonia. On the causative organism, pneumonia can either be community-acquired pneumonia or hospital-acquired pneumonia. And based on the severity, it can either be severe pneumonia or non-severe pneumonia. So onto our first classification, which is the etiologic classification, community-acquired pneumonia, it usually includes infectious pneumonia in patients living independently in the community. And the causative organisms include viruses. So as per the patch study, respiratory syncytial virus is the leading cause of community-acquired pneumonia, followed by parainfluenza, human metapneumovirus, influenza, and adenovirus. For the bacterial causes, Streptococcus pneumonia, Haemophilus influenza type B are the major causes of bacterial pneumonia. And for the HIV-infected infants, Pneumocystis jirovecii is the most common cause. And lastly, TB and atypical mycobacteria also cause community-acquired pneumonia.
Nabeela?
For the hospital, yes?
I'm sorry, we'll be interrupting you like we did the last time. If you can just go back one slide, please.
Okay.
Now, colleagues, Nabeela mentioned the PERCH study. The PERCH study is a very important study that was done throughout a lot of developing countries, sub-Saharan Africa, Southeast Asia, etc. And there were sites within Kenya, Kilifi, etc. What happened in this PERCH study is that they took children who had all the features of pneumonia and subjected them to a whole battery of tests. nasal swabs, throat swabs, bronchoalveolar lavages, blood cultures, urine cultures. It was very, very intense. Any pleural fluid was tapped as well. And so these studies and these etiologies that Nabeela is sharing with us today are those based on Kenyan studies. It was a very thorough and robust study. It's called the Perch study, PERCH, as in Nile perch. And what really stood out is that most of the causes of pneumonias in sub-Saharan Africa and in Kenya is viral, and in particular RSV. And I need you to watch this space because Nabeela is going to tell us something about how we're going to sort this out later on. Please remember that when you're talking about pneumocystis jirovecii, it was also a cause of in non-HIV infected infants. So that's something that you need to be aware of. And I need you to remember this next statement very clearly. Mycobacterium tuberculosis can cause acute pneumonia. And in up to 5 to 6% of all children in sub-Saharan Africa coming with acute pneumonia with no chronic history, my dear colleagues, mycobacterium was discovered. So tuberculosis can present acutely and chronically as well. And this is a very important, if there's anything that I would want you to remember from today, it's this one statement. Do not belittle the possibilities of mycobacterium causing an acute pneumonia, and you may need to investigate that in patients who don't respond to standard antibiotics. Nabeela?
Yes.
Carry on, Nabeela.
Okay, so for the hospital-acquired pneumonia, it's acquired in hospitalized cases, and the risk factors include for seriously ill patients, they can aspirate bacteria that colonize their oropharynx and the upper airways. Also, for prolonged mechanical ventilation, which can lead to ventilatory sorry. Can you hear me?
Yes, carry on.
Okay, so it can also prolonged mechanical ventilation can also result to, it's also another risk factor. Also impaired host defenses like immunodeficiency or steroids. And if there is any underlying conditions, like if there is cardiac, pulmonary, hepatic, and renal insufficiency, these are also risk factors. The causative organisms include gram-negative bacteria, which is the most common cause. Then there is gram-positive bacteria and opportunistic infections in immunosuppressed individuals. So for the gram-negative bacteria includes Enterobacter, E. coli, Klebsiella, Proteus, Serratia, Haemophilus influenza, Legionella, and Pseudomonas. For the gram-positive bacteria, it includes Streptococcus pneumonia and Staph aureus. And for opportunistic infections, they can be due to fungal causes like aspergillosis, histoplasma, cryptococcus, candida, and protozoal causes like in pneumocystis carinii infections. Mycoplasma pneumonia, chlamydia, and Legionella can also cause atypical pneumonia syndrome. So now we are going to the pathogenesis of pneumonia. First, we need to understand the modes of transmission. So it can be transmitted via airborne droplets from a cough or sneeze, direct contact with infected people, or through hematogenous, especially during and shortly after birth, or through infections such as meningitis. So once an inhaled infectious organism gets into the respiratory system, it must bypass the host defense mechanism before causing any inflammation of the lung parenchyma. So the host defense mechanism can either be an immune mechanism and immune-mediated host defenses. For the non-immune mechanism, they include filtering of inhaled particles or the cough reflex, mucociliary clearance, or secreted substances like lysozymes, complement defenses. And for the immune-mediated host defenses include macrophages, which phagocytose the pathogen, the microorganism, neutrophils, lymphocytes, and eosinophils. So once the inhaled infectious organism bypasses the host defense mechanism, it causes inflammation of the alveoli triggering leakage of plasma and loss of surfactant. This will result to the alveoli getting filled with pus and fluid, resulting to air loss and consolidation. This results to breathing, like difficulty in breathing, and also limits oxygen intake. So for the signs and symptoms, I'll begin with the symptoms. They can either be generalized or specific to the chest. So for the generalized symptoms includes fever, malaise, poor general conditions, which is worst in bronchopneumonia. And for the chest symptoms, it includes cough. It's usually dry, then it can then becomes productive, dyspnea, and grunting. The signs include respiratory distress. So this can be presented with tachypnea, nasal flaring, lower chest wall retractions, grunting, head nodding, and in advanced cases, there might be cyanosis and impaired consciousness. And on chest examination, so when you do inspection, there is decreased chest wall movement. And for this case, the side of the lung that is affected, for example, if the right lung is affected, you will see that the right side of the chest has decreased there's decreased chest wall movement on that side where there is the lesion. Then there's
Nabeela?
also chest wall in drawing. Yes.
Sorry to interrupt you. Now, my dear colleagues, I don't want us to panic as Nabeela speaks about inspection. I'll be honest, it's very, very hard to see a reduced chest movement on one side versus the other. Remember that these are children who are crying, they are in pain, they're having difficulty in breathing, etc. And remember, these are very small chest thorax that we're looking at. So in adult pulmonology, we'll turn on and say, look and inspect for chest excursions on both sides. But I'll be honest, because we are not here to stress colleagues, I don't look for it in pediatric patients, and I do not expect you to look for it either. Nabeela, carry on to palpation.
Okay, and on inspection, there can also be like use of accessory muscles. So for the case of pediatrics, you can see like head nodding because of the sternocleidomastoid muscle that is used. And for palpation and percussion, it's mostly normal in children. It's very hard to see it in a pediatric population. And on auscultation, you can hear crackles. You hear crackles and bronchial sounds. So for the complications.
Go back one slide, please. So, dear colleagues, we're looking at both undergrads and postgrads today. So for the sake of all of us, because we are always learning, we're looking for ALA flaring, ALA-NISA flaring. We're looking for the head bobbing. We're trying to listen for grunting or stridor or audible wheeze or audible crackles. We're looking at tracheal tugs. We're looking at sternocleidomastoid use. We're looking at intercostal recession, costal recession, subcostal recession, sternal recession. So a lot of these are signs of significant work of breathing. So I hope that we're all going through this carefully. We're looking at the nasal flaring. We're looking at the head. We're listening for sounds like I have mentioned. But look at the tracheal area, look at the apices of the lungs and see if you can see movement of the skin back and forth. Look at the intercostal area. The costal area is now at the level of the 7th, 8th, and 9th anterior ribs, and see if it's all moving in and coming out at the same time. In very young infants, you might even see the sternum going in and out. And then subcostal retractions means below the last rib, you can actually see retractions. You could even see paradoxical abdominal movement in those who are about to fatigue and who might actually need an urgent intubation. So you're also looking for cyanosis and reduced skin turgor. You're looking for an increased capillary refill, because these are also children who are very sick, and there are also other signs of infection that are in these children. So don't just look at the chest and rush for the stethoscope. Also remember that when you're auscultating, usually the IE ratio will not be affected. The IE ratio is maintained. Usually there's no prolonged expiratory time because the bronchioles and the bronchi are not affected. So what Nabeela is sharing and what we're learning from Nabeela is that you'll hear the crackles and you'll hear bronchial breath sounds only in areas where you have a consolidation. So if you do not have a consolidation, then you will not hear bronchial breath sounds. And if you're treating pneumonia and you find that you're hearing bronchial breath sounds in the right upper lobe, in the left upper lobe, and in the left lower lobe, chances are that you're probably wrong in your examination of this child, because you're not going to get multi-lobar infections that easily widely spread. It's a very rare thing to find multi-lobar disease. Usually it's just one lobe, and that's about it. Nabeela, also what I want us to do is give colleagues an opportunity to ask questions as we go along so that we don't lose people. I like to have questions along the journey rather than right at the end. So for colleagues who are listening to me right now, if you just put it in the chat box, your questions, and they'll come up on my phone, and I will also take them as we go along so that we don't lose each other along the journey. Nabeela, you can move to the next phase.
Okay, so for the complication of pneumonia, it can either be respiratory complications or systemic complications. For the respiratory complication includes pleural effusion, empyema with or without bronchopleural fistula and pneumothorax. There can also be lung abscess, pneumatocysts, septic emboli in pulmonary veins, and these are usually common in Staphylococcus aureus and Klebsiella pneumonia. There are complications due to Staph aureus and Klebsiella pneumonia. For the systemic complication, heart failure, pneumonia can result to heart failure. So this includes, like, we know that pneumonia is an infectious process, and it results to high metabolic rate. So patients with pneumonia are usually tachycardic, they have fever, and they usually have increased oxygen demand that can overwork the heart, resulting to, like, the heart can overwork, which can lead to heart failure. Also, on the aspect of septic shock, which is also a complication of pneumonia, septic shock can also lead to poor organ perfusion and leading to heart failure. We can also look at it at the angle of immunological inflammatory processes, leading to, like, thrombi formation, plaque formation in the vessels, leading to emboli, resulting to heart failure. Though for the immunological process, it's usually not common in children. Pneumonia can also result to distant infections like septicemia, meningitis, pericarditis, osteomyelitis, and arthritis. And lastly, there can be metastatic abscesses.
Nabeela? Thank you. You're starting to get used to me, yeah? Let's quickly answer Rahma's question. Rahma has asked a very important question about the role of vocal fremitus and tactile fremitus. I've always believed, Rahma, in the process of trying to simplify lung medicine rather than make it more complex. The truth is that the thorax is very small in children. And because the thorax is very small, it's very hard to accurately detect chest movements, one side versus the other, or vocal fremitus or tactile fremitus. So in pediatric pulmonology, we don't necessarily encourage one to do it. Now, Rahma might turn on and say, oh, but in the wards, Dr. A and Dr. B said, oh, we should check for these kind of things. The truth is that it's very hard to do these things in a 3-year-old, 1-year-old, 5-month-old baby, because, you know, how are you going to see tactile fremitus and feel it one side versus the other? I struggle, and I'm not going to lie about it. So in pediatric pulmonology, we're not here to stress you. What we're saying is that if a child comes to you coughing, breathing fast, has a high fever, and on auscultation you're hearing a crackle or bronchial breath sounds, or even not hearing any of the above, but breathing fast and coughing, then that is pneumonia, and you must treat as such. Nabeela, I wanted us to quickly go through these respiratory complications, if you can give me a minute. When it comes to pleural effusion, we are all clear that this is infection within the pleural cavity. that the pleural cavity normally has fluid there that is supposed to allow the visceral and parietal pleuras to move across each other smoothly during inspiration versus expiration. And so when this area gets infected, children will traditionally complain of chest pain, and they'll be splinting this area. And we talked about this last week. So when you have an infection in the pleural space, they have pain. So if your patient is not complaining of pain, it's unlikely, but that's something that you need to focus on. So empyema is if you don't treat that pleural effusion like you should, and that's a whole topic on its own. Lung abscesses are long-term complications. Pneumatoceles are complications of Staph aureus. So the point Nabeela was trying to make is that if you see a pneumatoceal, and pictures of this were recently posted on the Telegram undergrad group and postgrad group. So those of you who are not on it, talk to some of your colleagues, because there's a postgrad and undergrad Telegram group that we run together. And so the point is that if you see a pneumatoceal, think of staph, and if you think of staph, think of floxapen, flucloxacillin, stroke clindamycin as part of your antibiotic coverage. The rest, Nabeela, I thought you did very nicely, so I won't repeat what you said. Next slide, please.
For the differential diagnosis, we have asthma, cystic fibrosis, cardiac diseases such as pulmonary edema, which is caused by heart failure, and autoimmune diseases like SLE. For the investigations, you can either do radiological investigations or laboratory investigations. So on a radiological, we can do chest X-ray. So for the chest X-ray on our left, this is left, it is a right lower lobe pneumonia. And we can see that there is a homogeneous consolidation. So this is where there is the consolidation, homogeneous consolidation, and there is a sharply marginated fissure. So this makes it to be the lower lobe, whereby there's consolidation, and that's the lower lobe pneumonia. And for the bronchopneumonia, there is scattered opacities. As you can see, these opacities, they're scattered opacities in both the lungs. Then we can also do ultrasonography. This differentiates non-fibrinopurulent effusion and fibrinopurulent effusion. Contrast CT scan can also be done for complicated cases. And lastly, CT or ultrasonography-guided lung biopsy to diagnose infection with rare organisms.
Nabeela? Oh, are you going to go? Okay, fine. I think at this particular point, we should also be clear that you don't need to do a chest X-ray to diagnose pneumonia. Correct, Nabeela?
Yeah, true.
And that most of the time, we are not going to be asking for chest X-rays. So I'll give you an example of what we do at Aga Khan. So, sorry to use the word Aga Khan. It's not meant in a bad way. If you come in with cough and you're breathing fast, we'll do the blood test that you are going to share with us next. But we only do chest X-rays if the child, one, does not improve over a duration of time, or number two, actually comes in with signs that suggest that the child might have an effusion. I mean, if you have a lobar consolidation, you're still going to give the same generation of antibiotics. So we are trying to spare our children X-rays. So it's not something that is hot on our list. If you can just move to the next slide, Nabeela, for 2 seconds. Yes, for the ultrasonography, please remember that you're only going to do the ultrasound if you feel that there is an effusion. If you suspect an effusion. So if you're not suspecting an effusion, then there's no need to do an ultrasonography. By the time you're asking for a CT scan or CT guided or lung biopsies, etc., I don't mean this in a bad way, but at this particular point in time, you would really want a pulmonologist on board. You'd really want a senior pediatrician on board to help guide one to do that. That's not meant to belittle a colleague who is listening. It's just that by the time you ask for a CT scan, you really need to be sure that it's going to make a value difference to your patient and that is going to change management. My dear colleagues, forget the fact that we're discussing pneumonia today. There's something that I want to share at this particular point, if you can just allow me. There's something called your return rate. A return rate means that I decide to do a pregnancy test on 100 ladies in front of me because I think they are pregnant. And out of those 100 women, I get only one who's pregnant. So, you start wondering, why did I order 100 for a 1% pickup? I'm not saying that don't do pregnancy tests for women. What I'm trying to say is that you need to pick and choose your investigations very carefully. You are accountable to the Lord in the sky for the amount of x-rays you waste in children, for the amount of blood tests and pain you cause a child because you want to know a certain value and a certain number. So do not misunderstand the conversation. I am not saying do not investigate. I'm saying you have to investigate rationally. You need to be sure who needs a blood test. You need to be sure who needs an x-ray. You need to be sure who needs an ultrasound. Nabeela, you can move on.
For the laboratory investigation, we can do complete blood count, where we can get leukocytosis with predominant neutrophilia. In the cases of bacterial infection, there'll be neutrophilia. We can also do our C-reactive protein, procalcitonin, which will be raised. Also, respiratory biofire can be done, and it is a PCR-based test, which looks at viruses and atypical bacteria. Culture can also be done, blood culture, pleural fluid, or tracheobronchial secretion aspirate, culture and sensitivity.
Stop, Nabeela. Dear colleagues, so the hemogram is obviously going to be important. And, after working what our creators allowed me to work for these number of years, I have found this probably one of the most useful tests, despite everything else, because C-reactive proteins can also rise in other inflammatory conditions. Procalcitonin is more of a marker of bacterial infection, so that's useful. A lot of these tests are also useful, especially the procalcitonin, and also predicting when you need to stop your antibiotics. So C-reactive protein and procalcitonins and hemograms, we are hoping that you will not be requesting for these particular tests every single day. These are tests that you would want to do on the second or the third day, and especially when the child is not responding to therapy. Now, this point is very important, my dear colleagues. If you have a 3-year-old child who comes to you with what looks like a pneumonia, you start the child on antibiotics that Nabeela will guide us. And 2 to 3 days later, the fever is coming down, the work of breathing is coming down, and the cough is better, and the child is drinking. Why are we doing an X-ray? Why are we repeating blood tests? There is no need to repeat blood tests and X-rays on children who are responding to appropriate antimicrobial coverage. The respiratory biofire. Does anybody know how much a respiratory biofire costs? Nabeela, do you know?
Not really.
Can anyone quickly put it in the chat box? I want somebody to just guess how much a respiratory biofire costs in Nairobi. We want to have a little bit of a back and forth as well, colleagues. So just quickly put a few numbers. How much you think a biofire costs? Come, colleagues. A few numbers posted quickly, and then we can move on. Anybody? Chat box. Nabeela, take a guess. Okay, 10K, Marwa. Thank you. Thank you for contributing, Marwa. 7,000. I need you to go higher, guys. Come on, let's have some activity on this chat box. Don't go to sleep on me, guys. Okay, fine. All right, it's 25K. Thank you. No, not 50, Mr. K. It's 25. It's 25 to 30,000. Okay, thank you guys for contributing. Thank you. Jazakallah. It's around 25 to 35,000 shillings, depending on which laboratory you're getting the test done. So you see, it's not really going to change your plan of management. So it's something that you really, really need to think carefully before you do it. Also remember, Nabeela, that when you take tracheal secretions, remember that if all of us today are swabbed and we give sputum, we're going to grow something from the sputum because there's oropharyngeal colonization of bugs that our creators put there naturally. So it's something important to remember. Thank you for contributing, colleagues. Next slide, Nabeela. Oh, Nabeela, stop for 2 seconds. Let me just take some of these questions. How does respiratory biofire work? Thank you, Mohammed. You take a specimen, a nasopharyngeal specimen or an oral specimen, Mohammed, and then you take it to the lab, and that single specimen with 1 or 2 mLs of sputum can run and test for about 15 viruses, the ones that Nabeela has discussed, and about 10 bacteria, including COVID, including the mycoplasmal and chlamydial that we were talking about. And the results, Mohammed, come out within, depending on which lab you're running, between 6 hours and 20 hours. So it's quite useful. But the price is, I mean, how many of us can afford 30,000 shillings for a single test? And there was another question that I wanted to take now that I'm there. Is this the principle the same for adults, i.e. chest x-rays? Yes, the answer is yes. That was also Mohammed. But again, with adult disease, the chances of you getting lobar pneumonia and pleural effusions, etc., and complicated lobar disease is much higher. So adult pulmonologists would want to err on the side of more chest x-rays rather than not, but standard. You get your standard adult coming to you with cough and fever and breathing fast. You have no real reason to do a chest x-ray, Mohammed. You treat as pneumonia. So the principles are still not terribly far away. Nabeela, I think we can move on. Nabeela, remember, these are the slides where you're just supposed to highlight what you want rather than read the whole thing.
Okay. So for the management of pneumonia, if a child comes with a history of cough or difficulty in breathing and is more than 60 days old, and if there is any of these danger signs, like if there is oxygen saturation of less than 90%, central cyanosis, inability to drink or breastfeed, and if AVPU is less than alert, and if there is grunting. So if there is history of cough or difficulty in breathing with either of these danger signs, that will be severe pneumonia, and you should immediately admit the patient or refer, give oxygen, give IV penicillin and gentamicin, then continue monitoring the SpO2 and supportive care, like ensuring there is adequate hydration. Then, if the child has history of cough or difficulty in breathing and lower chest wall in drawing or fast breathing of more than or equal to 50 breaths per minute for the age of 2 months to 11 months, and if between 12 to 59 months, if the respiratory rate is more than or equal to 40 breaths per minute, that will be non-severe pneumonia, and you should give high dose amoxicillin, 40 to 45 milligrams per kg, twice a day. And you should counsel the mother on the danger signs. And you should review the child within 48 hours. And if the child cannot come with these symptoms. If the child has history of cough or difficulty in breathing with none of these signs, then that is cough or cold, there is no pneumonia. And if these symptoms present with a wheeze, that might be asthma, and it should be treated as per the asthma protocol. It's a different treatment plan. If there is treatment failure, so if a patient came with non-severe pneumonia, then progressed to severe pneumonia, you should admit the child, then change the treatment from amoxicillin, which was treating the non-severe pneumonia, to penicillin and gentamicin. And if you want to treat Staph aureus or gram-negative pneumococci pneumonia, you should give flucloxacillin and gentamicin IV. And if the child was presenting with severe pneumonia, but the child still gets worse despite being given the IV penicillin and gentamicin, the symptoms are worsening, then you should switch to second-line treatment, which is ceftriaxone, unless if you suspect Staph aureus, then that's when you should give flucloxacillin and gentamicin. And if the child is HIV positive, then suspect pneumocystis, pneumonia, and you should give high-dose cotrimoxazole and IV penicillin and gentamicin. If there is persistent of fever and respiratory distress, then you should then consider TB, you should perform Mantoux test, chest X-ray, and check TB treatment guidelines. So that's how you manage pneumonia. Then I'm going to the prevention of pneumonia. For the prevention, you should protect, prevent, and treat pneumonia. Under protection, you should encourage exclusive breastfeeding for the first 6 months. Because we know that breast milk is rich in immunoglobulins, which protects the child from several feeding. Balanced diet full of nutrients. Under prevention, vaccination plays a big role. So the vaccines include like measles vaccine, pneumococcal vaccine, Haemophilus influenza type B vaccine, pertussis, and I'll talk more about it in the next slide. You should also encourage hand washing to prevent the transmission, increases the risk factor of getting pneumonia, and household air pollution. Under treatment, improved healthcare seeking behaviors, improved care management at community and health facilities, continued feeding, and if a child comes to you and who has pneumonia, you should treat by giving oxygen and antibiotics. And antibiotics to prevent like the pneumonia getting complicated, then resulting to mortality and morbidity and mortalities. So the vaccinations for prevention of pneumonia can either be like the childhood immunizations, and there's the maternal immunization. For the childhood immunization, pneumococcal vaccine is usually given at 6, 10, and for influenza. And for the maternal immunization, there's a research going on the respiratory syncytial virus vaccination given to mothers. And the benefit of immunizing the mother is the baby gets the antibodies through the placenta. And lastly, COVID-19 vaccine also plays a big role in prevention of pneumonia. And these are my references.
Go back one slide, please, Nabeela. So colleagues, I think, sorry, the next one, the vaccine page. Thank you, Nabeela. So I think this part is clear when it comes to the pneumococcal vaccine and the BCG. With the pentavalent has the Haemophilus influenzae B. So we must not forget that, my dear colleagues, that there's a HIB vaccine in the pentavalent, and Haemophilus influenzae B is also one of the causes of pneumonia. It is also one of the major causes of meningitis. That's why the vaccine was made. But remember, its spin is that you also get protection to the chest. Measles, I believe, is self-explanatory because measles pneumonia and measles pneumonitis is actually very severe and life-threatening. Please remember, there's also the influenza vaccine that can be given to prevent influenza disease, which is also a cause of viral pneumonia. But remember that when you're talking about influenza, the world is in a lot of disagreement when it comes to pulmonologists. The efficacy of the influenza vaccine has varied between 20% and 66 to 80% over the past 1 or 2 decades. So many of us would have not gone for the COVID vaccine if we were told it's 20% efficacious. So influenza, remember, it's what you're giving the vaccine, hoping that you've understood what's going to be the serotypes and the shifts and the drifts of the antigens that you're going to use in the year that follows. So there's a lot of, I'm not going to use the word guesswork, that would be a totally wrong statement, but it's a lot of prediction, and our predictions usually aren't that great. So there's now a 4th serotype that has been involved. So it's 4th antigen that has been put into the newest influenza vaccine that was released last year. So we're going to see if that can increase its efficacy and its effectiveness in practice. So my default position, and this is one that I personally hold, is that I reserve the influenza vaccine for at-risk children, children with severe asthma, HIV, bronchiectasis, chronic lung disease, sickle cell disease, etc. So I don't personally advocate for the influenza vaccine as universal coverage for all children in Kenya. It is controversial. There are other colleagues who will have other opinions, but it's nice to listen to different opinions. It is not haram to listen to different people's thoughts. I wanted to share a little bit of my thoughts on the RSV vaccine. So it's given to pregnant women in the last trimester of their pregnancy, and it is safe. The newborns are not showing any signs of fetal abnormalities. And these are phase 3 trials that are going on right now. And it's shown that a lot of these children who are born are protected for the first year and a half against pneumonia secondary to RSV. Now, remember that for all these diseases, it's always a virus that invades the body that then sets the microbiota into disarray. I want that point to be clear. Nobody gets straightforward bacterial pneumonia. It's always a viral precipitant. There's always a virus that comes and invades the lower airways, and then suddenly the defense forces are overwhelmed, and then suddenly a bacteria or another virus multiply. That is how you get pneumonia. So if you can prevent young children from getting RSV by vaccinating their mothers, then by default, you'll have less pneumonia. Also remember that there is a lot of controversy on the role of RSV bronchiolitis causing asthma. So again, if we can vaccinate moms with the RSV vaccine, then we may have a preventative strategy to preventing asthma in the younger children. So that's something that's hot on the list and something that you need to be aware of. I can see that there are questions that are flooding in, and I would like you to post more so that I can go through them one at a time. So I'm going to start with where I left off. Sarah has asked if there's a situation where a respiratory biofire is a must. I think that would be, Sarah, in the land of a pulmonologist and a senior pediatrician. By the time you want to commit a parent to 35,000 shillings, you really need to, have a specialist in that area decide on that. So if it was somebody else doing it, I would suggest that when your back is on the wall and you've used multiple antibiotics and you have no clue as to the etiology of what is causing the pneumonia, that would be a good time to do the respiratory biofire. Najma, what would make you suspect Staph aureus? You would suspect Staph aureus if you have metastatic disease, i.e., you're seeing your liver enzymes are raised, you're seeing there's a little bit of a pericardial effusion, you're seeing your kidney functions going up, you're seeing pneumatoceles on the chest x-ray, and you're just not responding to standard antimicrobial cover. And you're seeing signs of necrotizing pneumonia and abscesses in the lungs. That's when you would suspect Staph aureus. I hope I'm not going too fast, colleagues. Slow me down if you want to. Fatima asks if there's a role of steroids in the management of pneumonia. A big fat zero, Fatima. No role at all. But Fatima, thank you so much for asking, because that's where we really mismanage. Fatima, can you imagine this 3-year-old child has pneumonia, and we are using our white cells and all our body defenders to fight that infection. And then we give you a steroid that immunodepletes you, raises your blood sugar, causes gastritis and so many other side effects. So there is no role for steroids in the management of pneumonia. Can we use palivizumab in the prevention of RSV? Yes, but now the costs, and you're going to give it to prem babies. So Badan says yes. How can you distinguish between acute bronchiolitis and from severe pneumonia? I love this question, Mohammed. Okay, so here goes. I hope I'm not going too fast, guys. Mohammed, can you guys keep up with me? Are you okay with that? Mohammed? Okay, I'll assume no news is good news. So here it goes, guys. Bronchiolitis, the fevers.
Enough.
Say again?
Hello?
Yeah. Mohammed, can you hear me?
Yes, doctor.
Am I going too
I'm
fast?
saying
or
your pace is good enough, not fast, not slow.
Okay, fine. So let me go back to.
No.
Thank you. I didn't want to lose colleagues. Okay, guys, this question is lovely. Bronchiolitis. So on the left, I would write gentle fevers, non-toxic child, and wheezing on auscultation, and hyperinflated on percussion. And on the right-hand side, I'd write raging temperatures, vomiting, toxic, not hyperinflated, no wheezes. My dear colleagues, pneumonia does not cause wheeze. When we listened to Nabeela, in one of her slides, she had a section that said wheeze, wheeze. And if the wheeze was present, you were being asked to think of other things. Pneumonia, please remember this, dear colleagues, this is an important statement. Pneumonia is a parenchymal lung disease. So you're going to get crackles. Bronchiolitis is a bronchiolar pathology. So you're going to get wheezes. So I love it when I hear a wheeze when I auscultate a child, because then I know I'm in the land of the airway and in the bronchi and the bronchioles. And if I just hear the crackles, crackles could be either pneumonia or bronchiolitis. But wheezes, it's the pipes. And I hope that point is very clear. Rahma is chloramphenicol used for first-line treatment. Chloramphenicol is an amazing, wonderful, beautiful drug, Rahma. And in my early days, we used to love that thing for meningitis and for pneumonia. But because of its side effects, which include bone marrow suppression, which can be very serious and very fatal, it is hardly available. But I promise you, I have used plenty of it in my younger days and it worked magic. And because we don't use it anymore, Rahma, I tell you, if I got my hands on it and I didn't fear bone marrow suppression, I would use it for some of these crazy pneumonias that I see, but it's not even available where I am. Nice question, Rahma. Can the color of sputum help identify the type of bacterial pneumonia? No, Ahmed, but thank you for putting a smile on all of us. Color of sputum, no. And I hope you don't ask me about the taste, Ahmed. Please repeat why you give RSV vaccine to the mothers and how it prevents spreading. Okay, thank you, Mr. K or Miss K. When you give a mother the RSV vaccine, the mother now starts producing antibodies. The antibodies then go through the placenta into the fetus. So now the baby is born with anti-RSV IgGs. And that is how you prevent it. I hope that's clear. Okay. Alvia, thank you. What happens when asthma is super infected with pneumonia? How do you then hear class? Oh, I like your questions, Mr. K. Let me put it this way. I have been treating asthma for the past 15 years, alhamdulillah, and I have used 3 antibiotics in all this time. And I treat acute asthma in hospital and privately as an outpatient, like maybe 5 to 10 times in a day. So it's, how shall I put it? Asthma is triggered by viruses and allergens, and pneumonia is triggered by viruses and bacteria. So it's very rare for us to need an antibiotic for asthma. And Mohammed, I think what Kay is also asking is very important, because we may need to do a session on asthma one of these days when people are ready. Now, Mohammed, are there any other questions? Because if there aren't, then we are going to close. It's almost 8. Mohammed, can you come online?
Yes. I don't see any other. Maybe if someone
so
has...
Mohammed, just 1 or 2 things then, but just stay online, Mohammed, if you don't mind. So number
Okay.
1, I was having a chat with Dr. Loving, and Dr. Loving felt that these sessions had gone on. He was comfortable with them, and I'm hoping that the large number of you who have come in today, I hope it has made a difference, inshallah. So Dr. Loving was wondering whether the Muslim Students Association would be interested in doing others, because he was of the opinion that he would also like to contribute as well, and maybe also Dr. Bashir and some of the other colleagues as well in the Muslim Students Association. So, and then also to follow up on topics that the colleagues would be interested in as well. I also likewise expressed my interest in continuing to do a few of these sessions as well. So it'll be for you, Mohammed, to talk to the colleagues who are here and find out what are the topics that you want, what you're interested in, what you think you need a pep talk on and a touch up on, etc. And we will be happy to oblige. So I will leave you to talk to everybody.
Thank you so much, Doc. Also, for the record, I was also in contact with Dr. Lavin. I told him that we are planning to have him on board for a pediatric gastro case. So inshallah, we really appreciate your willingness, and for sure we are going to have a session very soon on asthma, and we'll find out the best way to get suggestions from the colleagues. Then I can forward a list of topics to you and all the other seniors and lecturers, inshallah. Thank you so much, Daktari, for making time to again come and mentor us around this topic. We really, really appreciate it. We don't take it for granted. Also for Nabeela has, for the record, also has been waiting to present and has been really working on this for 2 weeks. So thank you so much for sacrificing your time to go and clerk and present and prepare all the slides. Sometimes you even struggle getting someone to present. So thank you so much. Also for the members, I really want to thank you for attending and engaging in the discussion. Inshallah khair, until next time. Assalamu alaikum wa rahmatullahi wa barakatuh. Have a lovely night.